The future of dermatology is being shaped today. Aesthetic and regenerative dermatology are advancing rapidly. New technology, new therapies, and new scientific discoveries are transforming how we care for the patient. As the Indonesian Society of Dermatology and Venereology, we believe that progress must always be guided by science, ethics, and responsible medical practice. That is why we established ARUNA Summit 2026, a scientific platform designed to connect dermatologists, researchers, and innovators across our region. We invite you to join us at ARUNA Summit 2026 in Jakarta and be part of this shared vision.
When we start designing ARUNA, we ask one simple question. What should the future of aesthetic dermatology looks like? Today, our field is evolving rapidly with new technologies, regenerative therapies, and expanding possibilities in aesthetic medicine. As innovation grows, one principle must remain clear. Aesthetic dermatology must remain inclusive, evidence-based, and appropriate for all skin types and colors. Indonesia reflects this diversity, with patients across all skin of colors. That's why the theme of ARUNA is Global Aesthetic for Skin of All Colors. We want to create a platform where dermatologists can exchange knowledge, share clinical experience, and advance treatments that are safe and relevant with diverse populations. We look forward to welcome you to ARUNA Summit 2026 in Jakarta as we explore the future of aesthetic dermatology together.
The future of dermatology is being shaped today. Aesthetic and regenerative dermatology are advancing rapidly. New technology, new therapies, and new scientific discoveries are transforming how we care for the patient. As the Indonesian Society of Dermatology and Venereology, we believe that progress must always be guided by science, ethics, and responsible medical practice. That is why we established ARUNA Summit 2026, a scientific platform designed to connect dermatologists, researchers, and innovators across our region. We invite you to join us at ARUNA Summit 2026 in Jakarta and be part of this shared vision.
Hello, good evening, distinguished speakers, respected faculty members, colleagues, and all participants joining us tonight. Welcome to the Webinar Pre-Event webinar held by INSDV in collaboration with Admire Academy India. It is a great pleasure to have all of you with us this evening for a scientific discussion on one of the most challenging and clinically relevant topics in dermatology, melasma management in Asian skin. Tonight, we are honored to have distinguished speakers who will share their expertise, evidence-based insights, clinical experience, and practical perspectives on melasma management. Okay, before we begin, allow me to briefly remind all participants that this webinar will be conducted in two sessions. The first will be the lecture. The first will be two lectures by Dr. David Sudarto Oria and Prof. Rasmi, and then followed by a question and answer. And then the second session will be the case-based discussion and also lectures by Dr. Ineke Jan Hidayat and Dr. Asim Sharma. We are encouraging everyone to actively participate by submitting questions through the question and answer box or the chat box during the session. And to please share every valuable insight we have today in social media, as we will have a lot of gifts and free day passes for ARUNA for the best social media post, both for national and international participants. We also have special offers for everyone who participate in this webinar to join ARUNA Simposium and Workshop with a promo code that will be active 3 days from now. So, to officially open tonight's webinar, it is my honor to invite Dr. Hani Nilasari, dermatologist venerologist, as the president of INSDV to deliver the opening speech. Dr. Hani, the screen is yours.
Thank you, Dr. Anesha. Good afternoon, distinguished speakers and also respected colleague and dear participant. First, let me show my deepest gratitude to President of ARUNA International Summit 2026, Dr. Danang Triwahyudi, INSDV FADV, and also distinguished speaker David Sudarto Oria, MD, and INSDV FADV, Rasmi Sakar, MD, PhD, FEMS, IFEED, and Asim Sarma, MD, NDB, MBA, FRCP, TBD, and also Dr. Ineke Jan Hidayat, MH, SC, FINSDV. And Chairperson, Dr. Listia Paramita, FINSDV, and honored professor, respected senior colleague, fellow professional, and all organizer, committee members, and also participants present here who contribute and took a big role in this activity. It is my great pleasure to welcome all of you to this Aruna Admire Academy webinar with the title Melasma Breaking the Myth, Building the Evidence. As the President of Indonesian Society of Dermatology and Venereology, or INSDV, I am proud to see the scientific collaboration taking place as a part of a journey toward Aruna International Summit 2026. INSDV is the official national professional organization representing dermatologists and also venereologists across Indonesia. Our mission is not only to strengthen dermatologic education and clinical practice, but also to build a stronger academic ecosystem where Indonesian dermatology can engage, contribute, and lead in the regional and also the global conversation. Aruna was created with that vision. Through Aruna, INSDV aims to establish an international scientific platform that reflects both global excellence and also the realities of dermatology in our part of the world. Indonesia is a country with rich diversity in skin types, ethnic background, and also clinical challenges. Therefore, our contribution to global dermatology is highly relevant, especially in areas such as pigmentary disorders, aesthetic dermatology, and skin of the color. Today's the topic melasma is an excellent example. It remains that good dermatologic care must be based on not only the treatment trends, but also on evidence, clinical judgment, and long-term patient-centered strategy. Through this webinar, we hope to encourage meaningful scientific exchange, strengthen
Thank you, Dr. Hani, for the opening speech. Next, we have Dr. Danang Triwahyudi, dermatologist and venereologist, as the president of ARUNA, to deliver his greetings to all of the faculty and participants.
Thank you, Dr. Anesia. Good evening. Assalamualaikum warahmatullahi wabarakatuh. Distinguished speakers, respected colleagues, and dear participants. First, let me show my deepest gratitude and acknowledge the President of the Indonesian Society of Dermatology and Venereology, Dr. Hani Nilasari, MD, PhD, PhD, FADV, founder and the director of Admire Academy, Ashim Sharma, MD, DMB, MBA, FRCP, TPD, distinguished speakers and panelists, Dr. David Uria, PhD, FADV, Professor Dr. Rahmi Sharkar, MD, PhD, FAMS, IFAAD, Dr. Ineke Jane Hidayat, MA, SC, PhD, Dr. Atullah Gupta, Fellow, EAD-VL, Dr. Ishat Anggarwal, and also the chairperson, Dr. Listia Paramita, MD, PhD. Honored professor, respected senior colleague, and fellow professional, and also all the organizers, the committee members, and the participants that are present here who contributed and took a big role in this activity. It's an honor to welcome you to this pre-event of Aruna International Summit 2026 in collaboration with the Admire Academy with the theme Melasma, Breaking the Myth, Building the Evidence. Aruna International Summit 2026 will be held in Jakarta on September 4 to 5, 2026, under the theme Beyond Borders, Beneath the Skin, Global Aesthetic for Skin of All Colors. Aruna is designed as more than a scientific meeting. Aruna is envisioned as a platform where dermatologists, aesthetic physicians, and global experts can exchange knowledge, challenge current practice, and discuss the future of dermatology and aesthetic medicine with a strong focus on skin of colors. As part of the Road to Aruna, we are organizing a series of scientific activities to build awareness, stimulate discussion, and bring our colleagues closer to the main summit. Today's webinar is one of those important steps. We are also particularly delighted that this pre-event webinar is conducted in collaboration with Admire Academy. We sincerely appreciate Admire Academy for partnering with Aruna in this webinar. We believe that this collaboration represents more than a single educational event. It marks the beginning of a meaningful academic partnerships that will continue to create opportunities for learning, innovation, and international collaboration in the years ahead. We choose Melasma as our theme today because it remains one of the most relevant and challenging conditions in daily practice. It is a condition surrounded by many misconceptions, both in the public perception and clinical management. Therefore, this webinar is not only about updating knowledge, but also about strengthening evidence-based thinking, improving clinical decision-making, and building more responsible patient care. At Aruna 2026, we will continue to spin through expert discussion, case-based session, debates, workshop, and the next gen stage for oral and poster presentation. We hope that Aruna will become a meeting point between experience, science, innovation, and future leadership in dermatology. On the behalf of the Aruna Organizing Committee, I would like to sincerely thank Dr. Hani Nilasari and the INSDV for their continued support and also for the Admire Academy for this collaboration. Our distinguished speakers and moderators and all our participants who have joined us today, also thank you very much. May this webinar become a meaningful beginning to the Aruna journey, and it may inspire deeper scientific action leading toward Aruna International Summit 2026. Thank you, and please enjoy today's webinar.
Thank you, Dr. Danang, for the warm greeting to all of our faculty and participants. So before we begin our session, I would like to invite Dr. Asim Sharma as the president of Admire Academy from India to also give his greetings for tonight's session. Dr. Asim, the screen is yours.
Thank you so much. Thank you, Dr. Anisia. Thank you, everyone from INSDV, Aruna, and my fellow Admire Academy members. I think this is the start of a wonderful collaboration. And if you look at India and Indonesia, we're separated by one ocean or the Bay of Bengal, but we have a lot of similarities. We have very deep-rooted history of using Sanskrit together. In fact, both India and Indonesia, the word itself comes from Sanskrit. We come from lands where a lot of traditional remedies are used for conditions such as melasma. We both are countries which are obsessed with fairness, where our patients want to become fairer and fairer and fairer. And we are tropical, where we have high UV, high humidity, and high heat. So it becomes difficult for all of us to contribute to a condition like melasma. But the most research that happens across the globe in melasma, most of it comes from South Asia. So we are also pioneers in the field of melasma to speak of, and which is why this becomes the perfect first webinar to collaborate between Aruna, INSDV, and Admire Academy. And I'm hoping and praying that this is the start of many, like Professor Danang also said. And all the best to all the speakers. And thank you so much for having Admire on board. And to everybody who's logged in, please send in questions. All of us are raring to go and to answer each and every question that you have in the audience. Thank you very much. And I'm going to hand back to Anisia to continue the meeting. Thank you.
Thank you.
Thank you very much, Dr. Ashim. And thank you for all of the faculty, especially the faculty from Admire. Thank you for this collaboration. And hopefully this will be the start of a lot of more collaboration in the future. So without further ado, I would like to proceed to the scientific section. To guide us through tonight's discussion and also lectures, it is my pleasure to invite Dr. Listia Paramita, dermatologist, venerologist, who will open and moderate both the first and the second session. Dr. Listia Paramita is a distinguished Indonesian dermatologist. She is now the founder and medical director of Skin Daily Clinic in Pekanbaru, and she has been a very active presence both in social media and also in national and international conferences as both speakers and educators. Dr. Listia Paramita, please kindly take over the session.
Thank you, Dr. Anesia. Good evening, everyone. Good evening, dear participant and distinguished speaker. On behalf of the organizing committee, I would like to warmly welcome all of you to today's scientific webinar entitled Melasma, Breaking the Myth, Building the Evidence. It is a pleasure to have you joining us from various locations from India, Indonesia, and also from Vietnam to discuss one of the most challenging pigmentary disorder in clinical practice. Melasma remains a common yet complex condition that significantly impacts patient quality of life. Despite advances in dermatological science, many misconceptions regarding its pathogenesis, diagnosis, and treatment continue to exist. Through today's session, we hope to bridge the gap between myth and evidence by exploring the latest scientific understanding and evidence-based management strategies. Thank you for taking the time to be with us today. My name is Paramita and I will have the privilege of serving as your moderator for this webinar. So, ladies and gentlemen, it is my absolute honor to introduce our first speaker for today's session. He is a highly accomplished expert and true pioneer in the field of dermatology and dermatologic surgery, both in Indonesia and internationally. Dr. David Sudarto Wirya, SPDVE, FINSDV, FAADV, IFAAD. Dr. David completed his medical degree at Erlanger University in 1982. He then pursued advanced specialized education in Japan at Kanazawa Medical University, where he qualified as dermatologist in 1990 and later as a dermatology surgeon in 1997. His commitment to advancing the medical community is reflected in his extensive networks nationally in Indonesian Medical Association, in Perdoski, and various study groups focusing on skin tumors, laser dermatology, and cosmetic dermatology. On the global stage, Dr. David holds membership in numerous world-class organizations. Today, Dr. David will be sharing his profound expertise on a highly relevant and crucial topic, melasma algorithm management in Asian skin. Dr. David, you have 20 minutes and the screen is yours.
Thank you, Dr. Paramita. Thank you for your very kind introduction. Thank you for everyone for inviting me to speak here. Good afternoon. Thank you for everyone to attend this, and thank you for the organizing committee to invite me to speak here. And thank you, Dr. Paramita, for your kind introduction. Let me share my screen. Yeah, my talk today is about beyond the epidermis, a multimodal algorithm approach to melasma in Asian skin. What I'll be talking in 20 minutes time is about what I'm doing in my daily practice for my patients with melasma. My disclosure is I'm the clinical user of photoanalysis system and the trainer of the photoana educational programs, but no other relevant financial conflict of interest to disclose. My outline is to describe the modern concepts and recognize the roles of dermal, vascular, and inflammatory factors, and especially in my talk is about Asian skin is different. And also understand the rationale of multimodal treatment and also integrate a laser system into the treatment clinical practice. So I will go through this slide. Yeah, the melasma, I think as we all know that we know there's an epidermal melasma, dermal melasma, and mixed melasma. The most difficult part to treat is derma melasma. And also there's also mostly centrofacial, mandibular, and malar, and mostly of our patients are centrofacial, and some have mixture as well. So we can see better under dermoscopy and with lamp to know where the melasma, and as we know that many of the melasma patients is not purely epidermal or purely dermal, but most are mixed melasma. In the aesthetic dermatology, the treatment of melasma with a magic bullet mindset, looking for the aggressive laser or ultra strong peeling or long-term strong hydroquinone plus topical steroid to erase the pigment quickly is a faster way to trigger a therapeutic disaster. Successful management requires a multi-targeted long-term strategy rather than a single quick fix. It is not a sprint, it is a marathon. So we try to avoid that harsh or strong treatment, but we have to approach with multi-targeted long-term strategy. And also we have to rule out the pregnancy, hormonal contraceptive, and hormonal replacement therapy for all those patients that come to us with melasma. And also we assess the workplace heat and lighting exposure. The melasma is matter, as we don't know, that decrease the quality of life for the patients. And also it is quite very challenging and frustrating for the patient because they're keep coming back. As we know, the traditional concept of melasma, these are epidermal models. We think that melasma is a melanocyte and melanin problem in the epidermal, and we just therefore focus on topical and physical modalities targeting the superficial surface layers, like hydroquinone formulation, chemical peels, pigment targeting lasers, Q-switch nanosecond, and so on. So because of this concept, so we use the superficial treatment, and like we know that sun protection, hydroquinone monotherapy, and then it doesn't work, and we go to triple combination cream and chemical peels, and then it doesn't work, and we go to laser treatment. And it is not the way that I'm doing. The modern concept melasma is a complex photoaging disorders. Pigment is the manifestation, not the disease itself. Multiple pathways contribute, including pigmentary, dermal, vascular, inflammatory, and environment factors. And we also know that multifactorial pathogenesis of melasma, that including the epidermis and dermis, melanocyte, keratinocyte, fibroblasts, mast cell as well. So they involve different layers and different cells. So my treatment is to target all pathogenic pathway simultaneously, not sequentially. So we have to do the comprehensive assessment, and then photo protection. And the very important thing is the visible light protection should have been done for the patient, and heat control. So we target multiple pathogenic pathway simultaneously. Like we treat pigmentary pathway with triple combinations, cysteamine, hydroquinones, and also dermal pathway, we use fractional picosecond lasers, and also vascular pathway, we use an oral or topical tranexamic acid, and inflammatory pathway, we calm the skin with barrier repair and gentle care. And let the pigment fading, and then improve the skin quality, and we reduce the recurrence and also for the long-term maintenance. The traditional treatment often fail because we do not target all the pathogenetic factors. So disorders of the skin microenvironment, I think it is the underlying factor for the melasma. And then there's melanocytes, keratinocytes. This is located in epidermis, and then fibroblasts, endothelial cells, mast cell is in the dermis. And then also UV radiation. We always forget the visible light, heat, and oxidative stress. So we treat all these components together. So I will skip this one. And also about the base membrane disruption. So we have to repair the basement membrane disruption at the same time as well. And because the disruption allow pigment to drop and migrate into the dermis. Because you know that sometimes the superficial or epidermal type of melasma, and after treatment, it become going down to become dermal type of melasma because of the disruption of the basement membrane. And dermal melanophages, and that melanin go into the dermis were eaten by macrophage, and then so it become dermal pigmentation. We call it dermal melanophages. So not all melasma pigment is epidermal, so as we know the previous slide. Fibroblast dysfunctions. Senescent fibroblasts that produce stem cell factors, especially hepatocyte growth factors, W and T molecules, but especially SCF, that contribute much of the activity of the melanocyte to produce more pigment. The vascular component also becomes vascular endothelial growth factor, also stimulate the melanin to produce more pigment as well. As we know that many of the melasma lesions show underlying erythematous component. But we know some of the patients that come, I think many of the patients come to us is not a virgin patient actually. They are treated before by steroid or something. And then the vascular component is not necessarily only come from melasma, but it is because due to the previous treatment itself. And oral tranexamic acid decrease in the numbers and activity of mast cell in the dermis, reduction in the formation of new blood vessels. So that we treat the inflammation component, usually the one that you are using not an oral steroid, but using oral tranexamic acid. Solar elastosis is because this solar elastosis on the melasma skin if compared to the surrounding skin. And we know that melasma is part of the photoaging. And the presence of melasma skin demonstrates accelerated photoaging compared to adjacent normal skin. So we know that the melasma is a part of the photoaging. So we have to treat it as well at the same time. And about the visible light and underestimate triggers. High energy visible light, there's blue light, 400 to 500 nanometers, particularly important in Asian skin. And as we know that everyone and every day we're exposed to the screen, TV screen, computer screen, and as we know, we have to measure our screen time, how many hours of the screen time in a day, and especially for a lady who work in the office workers, so we need the protection of the high energy visible light with iron oxide containing sunscreen. It means sunscreen that contain color. Also heat-induced melanogenesis. So we have to ask our patient the cooking, the saunas, hot yoga, they also can cause melasma to recur after the treatment. So melasma is a systematic skin issue pathology, actually. So melanocyte-based membrane, fibroblast, blood vessel, mast cell, photoaging. So we have to treat all these factors. The Asian skin, in Indonesia, most of our patients are from type 3 to 4 to 5 skin. And most of them are 3 to 4. And they come to us with the melasma. this skin type, they are more reactive, labile melanocytes, greater basement pigment production, significantly higher PIX risk, greater and more sustained visible light response. And also, we are living in tropical zones. And any excessive inflammatory treatment by introduced by the treatment may dramatically worsen the pigmentation. That we always hear that after the treatment, the pigment improve a little bit and then later become worse. Therefore, treatment should minimize unnecessary tissue injury. So try not to very aggressive. And also, we have seen many patients treated with nanometers 1064 lasers tuning and end up with mortal hypopigmentation of confetti light disorders. Yeah. So by treatment goal in Asian skin is not perfection, not complete clearance, but long-term disease control. Yeah. So the first one is pigment suppression, vascular control, dermal remodeling. My very first step is strictly tinted photoprotection, comprehensive trigger avoidance, heat and light, and also initiate topical treatment for initial clearance. And at the same time, we do it at the same day or sometime 1 week, 2 weeks later, we immediately start using lasers, fractional picosecond lasers, and also picosecond toning. Okay, we can do it at the same time. And also use oral tranexamic acid 250 milligram BID. The other thing is that we have to tell our patient the lifelong photoprotection, transition to non-hydroquinones, and also maintenance with infrequent laser maintenance if needed. So strict photoprotection, and then how much sunscreen should be applied. And most of our patients actually apply underdose, and they apply, they think they apply a little bit of sunscreen and can get a full protection. That is not the case. So enough for to protect the skin, and if they exposed to sun, have to repeat it again. Yeah. Also thermal avoidance and also gentle skin care, because some patients use a scrub in it as well that can destroy the skin barrier. So medical treatment, as we said before already, and oral tranexamic acid. And the why energy-based device matter? Because we can get faster pigment clearance than a topical alone, and also improve patient satisfaction and compliance. Because the patient adherence is very important. Once patient gets some improvement, they will adhere with us and follow our instruction. So the major limitation is EBD cannot replace the trigger control or medical therapy. EBD as an adjunctive treatment. Previously, everyone was using nanosecond laser few seconds, and now we are moving to picosecond lasers. Yeah, because the picosecond laser, there is 70 to 80% photoacoustic. It's less heat. Y1064 is a deep penetration, lower epidermal absorption, and safer for Asian skin. So I have to say the brand of the lasers, because not every laser have the same parameters and also have the same handpiece as well. The one I'm using is the Photonastar Worker PQX fractional 300 picosecond 1064 nanometer lasers, and there is a focal length -1 to -2 millimeter. That means that they focus the energy beneath the epidermis to repair the elastocyte and the base membrane. And because of the 300 picosecond, it's a cold breakdown, IOB, and also safer for Asian skin. Because our target is not target the epidermis, we are targeting the upper dermis. Yeah, so I skip this one. Yeah. And then what we get from laser is the epidermal and dermal pigment, actually acoustic wave that can shatter and then destroy some of the melanin inside the epidermis, and also collagen remodeling and microenvironment remodulation to treat the skin aging. And then we destroy the stubborn dermal melanophage, sorry, not melanin, melanocytes, sorry, melanophages into ultrafine particles. Beyond pigment removal, so our treatment actually is beyond treatment removal. We improve the microenvironments that affects the activity of melanocytes. This is some of my patients when come to me so that they were treated before with online treatment, and I don't know where she get the treatment and become darker and darker. And what I check is the usage of sunscreen, enough sunscreen, thick enough, and also SPF, high SPF, but under application. So the application of the sunscreen below the dose is not effective as well. So we have to apply thick enough, and also sunscreen with iron oxide, is mean with color. And in this patient, I combine with TCC, 3 combination cream, and tranexamic acid, 250 milligram BID. When since the first day, patient come to me, and then the next week, I use 300 picosecond toning. With only 0.6 joule per centimeter square in only very slow 5 Hertz only. And the next week again, I do another treatment with 300 picosecond fractional F9 focal length -1, 1.5 millijoule per pixel. This one I'm using 10 Hertz. So what is my endpoint? My endpoint, I don't see the endpoint actually. I don't see the endpoint. Yeah, because when you see the endpoint, because the endpoint, the reaction, the tissue reaction will come a few minutes later. So we just do it once passes and then done. Yeah. In some patients, after 5 minutes, you see the redness, erythema. Yeah. And then, so we don't expect to see the endpoint immediately. This is the patients. We do the same treatment. So all these patients I show you is using the same algorithm, same protocol. Yeah. So it is not completely clear, and you see that 22 of January is March. Yeah, it is about 1.5 months, and you can see that it is improvement. Yeah. This 17th of April and 23 of it is about 2 months, about 2 months, and we see the improvement of the skin. Yeah. So take home message: the melasma is beyond the epidemic. It is a chronic photoaging disorder of the entire skin. Dermal vascular inflammatory pathway should be treated. Asian skin require low inflammatory strategy to avoid PIX. Our skin type is easy to get PIX, especially we are living in tropical zone, and we cannot avoid the sun totally, but we try as much as possible. And also fractional picosecond technology address both pigment clearance and necessary dermal remodeling safely, and long-term success strictly depend on multimodal treatment algorithm and dedicated maintenance. And I think the patient adherence is very important. So have a good communication with the patient and tell the patient, set the do not promise too much. So we deliver more than we promise. Yeah, I thank you very much. Yeah. If the audience have a question, let's discuss later. Thank you.
Thank you so much, Dr. David, for the excellent and insightful presentation. For participant, if you have any question for Dr. David, you can directly drop your question on the Q&A box. So let's continue to our next speaker. Our next speaker is a globally recognized leader, academic, and expert in the field of dermatology, Professor Dr. Rasmi Sarkar, MD, FAMS, IFAAD. Looking into her exceptional education background, Professor Rasmi completed her MBBS at the MGM Institute of Health Sciences in Bombay, followed by her MD in dermatology from Bharati Vidyapith University in Pune. Professor Rasmi
I think
currently...
this is not my CV. I think this is somebody else's because I didn't complete it from Mumbai.
Oh, sorry, Professor. Okay, so today we are privileged to hear her insight on highly anticipated and critical topic, melasma management guideline, evidence-based takes on melasma. Professor Rasmi Sarkar, you have 20 minutes and the screen is yours.
So I'll just share my screen.
Yes, it's clear, Professor Rasmi.
Is it available? Yeah. Are you able to see it?
Yes, clearly.
Yeah. Just a second. So, good evening, everyone. And it's a pleasure to be here in this particular webinar, which is by the ARUNA Academy, as well as also by the Admire Academy, which is from India. And I think I'll just introduce myself because the slide was somebody else's. So I'm Dr. Rashmi Sarkar, and I'm a director professor and head of dermatology at Vardhaman Mahavir Medical College and Safdarjung Hospital, New Delhi, India. I also happen to be the president of the Pigmentary Disorders Society, and I've also been a past president of the IIT Will. And the reason why I'll be presenting this talk today is this is based on one of our international publications which has happened in JEADV, which is in April 2026. So I'll be talking about that publication. Just give me a second. There's a noise actually. Anjali? So I'm going to talk about an international consensus on the management of melasma, an evidence-based guideline. And this is, of course, based on a Delphi-based consensus involving an international expert panel in collaboration with the Pigmentary Disorder Society. So this is evidence-based. And again, following Dr. David's talk, it is partly algorithmic. So in fact, this is the paper that many of us participated in. It was a Delphi consensus, and I was myself there. Dr. Seema Lal Desai was also the co-chair, and you can also see that Dr. Asim Sharma was also one of the participants and one of the persons involved in this publication, which is the Delphi Consensus on Melasma Management by International Experts and Pigmentary Disorders Society. So there were about 40 members, 40 dermatologists. As I said, it was chaired by me and co-chaired by Dr. Seema Desai. There were 38 other people, and they represented different parts of the world, whether it was Asia, Africa, Australia, North America, South America, and just about every part of the world. So we had a pretty good involvement of people, and it was globally, you can say it involved a lot of people with different ethnicities. So as we know, melasma is a condition, it's a chronic condition which can affect individuals across all ethnicities. Though its prevalence is particularly pronounced more, in skin types which are 3, 4, 5, and 6, and photo-exposed populations. Beyond its physical manifestations, definitely it causes a lot of emotional and psychological stress. Hence, this leads to the deterioration in the quality of life. That is exactly the reason why we talk about different treatments and also multimodal treatment. The management of melasma is further complicated by its multifactorial pathogenesis and high relapse rates. One issue is that no longer it is just about the melanocytes and the melanin, which are the most important part in melasma. It's a lot more. There's a role of the keratinocytes, there's a role of the fibroblasts, mast cells, vascular factor, and so on. So it's a lot more than we think it is. There is also a variable response to treatment modalities and the lack of prospective randomized trials for many therapeutic approaches, which complicates the choice of the most effective regimen. The variability underscores the necessity for ongoing research and updated clinical recommendations, which can provide a structured approach to management. So this particular initiative was an extension of a previous consensus that we had done from the Pigmentary Disorders Society. This was published actually in the November-December issue 2017 in the Indian Journal of Dermatology. It's an entire symposium of melasma in case you want to read, and it's open access. It's just that this one had an extended geographical coverage and a larger panel. The main objective of this consensus was, of course, to analyze current clinical practices, evaluate existing evidence and recommendations, and develop a consensus-based framework to optimize diagnosis and management strategies. We acknowledge that management strategies are different across the world, and that was exactly why this was being done. By identifying best practices and highlighting evidence gaps, the consensus aimed to step towards standardizing care. As I mentioned, it was a modified Delphi approach with 3 rounds of voting and 2 virtual meetings. The core group had 2 senior members who oversaw the process, a panel of 38 experts from 11 countries who voted on the statement. The PubMed research was essentially a 10-year strategy, 2014 to 2024, focusing on diagnosis and management. From here, important statements were picked up, which needed a consensus. And evidence was graded using the Oxford Levels of Evidence, which is 2009. So this is how it was done. The core members and expert panel were finalized. A comprehensive literature search and review of the diagnosis and management of melasma was undertaken. Research gaps were identified. Several consensus statements were developed. The level of evidence was determined and the grading was performed for the statements generated. Statements were then mailed to the expert panel for voting on a Likert scale using a virtual platform. And the statements were then discussed on a virtual meeting to either retain them, revise them, or remove them. The revised statements went through a second round of voting, and finally, statements were finalized in the third round of voting and discussion. So as you can see, it was quite a meticulous process. So on the left side, what you see is the 5-point Likert scale, which is strongly agree to strongly disagree, with neutral being in between. And when more than 75% of the participants strongly agreed, or disagreed or strongly agreed with the statement, that was taken as a high level of consensus. 55 to 74% as moderate consensus, and less than 55% of the participating agreeing or strongly agreeing or disagreeing with the statement as low consensus. So let's have a look how it was done in the process. About 34 consensus statements were put up. The outcome after the first round was high consensus was reached in 16 statements, moderate consensus 13, low consensus at 5. The number of statements retained were 7, reframed were 19, and removed were 8. Outcome after the second round, those that reached a high consensus were 20, those that reached moderate were 5, and low consensus was 1. Statements which were retained were 18, and statements reframed were 8. So outcome after round 3, those that reached high consensus were finally 21, moderate consensus 4, and low consensus 1. So that was what was retained, that is the high consensus, which is 21. Let's have a look at the outcomes. First of all, what about diagnosing and monitoring melasma? We know that it is a clinical diagnosis. Wood's lamp remains a favored method for determining the extent and severity of melasma, but the constraints in accurately determining melanin depth may limit its use. We know that it's a good, simple device that we have, especially in, Asian countries, to look for melasma. On the other hand, dermoscopy is an accepted and non-invasive tool that can facilitate the differential diagnosis, whereas reflectance confocal microscopy is helpful only where available. It's not available a lot. Finally, consider a biopsy if the diagnosis is uncertain. We should not hesitate if we have uncertainty. Coming back to photoprotection and skincare, which has been elaborated by the first speaker, photoprotection undoubtedly remains the cornerstone of melasma care. The characteristics of an ideal sunscreen should include broad spectrum coverage with protection against UVA, UVB, and visible light. Visible light is very important. An optimal sun protection factor should be there, and cosmetic acceptability. So either we can use one having coverage for visible light, or otherwise we can use a broad spectrum one, UVA, UVB, cover it up with a foundation. Addition of active ingredients such as antioxidants, depigmenting, and moisturizing agents to sunscreen can increase its efficacy in managing melasma, enhance the skin's tolerability to topical treatments. Now, we've talked about barrier, repair and, barrier permeability in melasma. While transdermal epidermal water loss in melasma lesions is similar to the surrounding skin, the barrier recovery rate in lesional skin is significantly slower, leading to reduced moisturizing capabilities and forming a vicious cycle, all the more that there has to be barrier protection. Moisturizers are beneficial in reducing treatment-associated dryness, irritation, and thus enhance patient satisfaction. So these are some basic important things in maintaining the treatment. Now, looking at the outcomes of topical therapy, first line, the panel felt that triple combination cream definitely is something which is quite important. In a patient of melasma, the hydroquinone 4% containing one with tretinoin 0.05% and fluocinolone acetonide 0.01%. However, regarding its use and duration, it was felt that initially intensive daily therapy can be given up to 12 weeks. Now, it doesn't mean 12 weeks in all patients. What it means is up to 12 weeks. You have to individualize the patient. It could also be 8 weeks or less. Then twice weekly maintenance, taper to non-hydroquinone topicals as appropriate, and clinical supervision is recommended. Newer non-hydroquinone-based options as viable alternatives are there, especially in patients who are intolerant to first-line agents, have contraindications or require maintenance therapy. So we know that there are many new kids on the block, like there is thymidol. There is also Melasil, which is there, there's histamine. There is metformin topically, which is available, and Melasma. So what about topical alternatives to oral, topical and also oral agents? I already talked to you about some new kids on the block, but azelaic acid is an effective treatment option for patients who cannot really tolerate the adverse effects of hydroquinone. Antioxidants such as topical vitamin C can be beneficial. And then combination with ingredients like kojic acid, arbutin, vitamin E, and botanical ingredients may be used as additional options. Remember that most of these non-hydroquinone agents are used more as a proper cocktail. Oral tranexamic acid is effective in the management of melasma. The expert panel was in favor of oral administration due to its proven comparative clinical efficacy, offering a balance between effectiveness and convenience. So more than the intradermal route or the topical route or the oral tranexamic acid. The suggested dosing was 250 milligram twice daily for 12 weeks. Before starting therapy, it was important to take a history of risk factors for thromboembolism, cardiovascular or coronary artery disease, menstrual disorders, and to assess for any contraindications. Oral antioxidants in combination with other appropriate treatment modalities can also serve as an option. I go over to the next line of treatment, chemical peels. What we found from the evidence was that glycolic acid is the most studied peel and shows superior outcomes compared with others. Other options include salicylic acid peels, retinoic acid, trichloroacetic acid peels, though in darker skin like we have, it should be low concentration, probably 15% or so, and Chester's peel. Some of the refractory melasma can be treated by using a combination of a depigmenting agent, 4% hydroquinone, triple combination therapy, and a peeling agent. Combination peels may be used as an additional option for the treatment and maintenance of melasma. Regarding other procedural treatments, yes, they're important. Microneedling is definitely something that can serve as an effective procedure. First, to improve the quality of the dermal matrix. What it does is it lays down the collagen in a more organized way and also improves the penetration of topical agents. Of course, more evidence is needed, but we know that it does have its effect. There was a low consensus on the use of platelet-rich plasma as an adjunctive therapy, although there are several studies which show that it works well as an adjunctive agent. Low-fluence Q-switched Nd:YAG laser can be a suitable option for refractory cases, and though effective, laser therapies require careful patient selection and are best reserved for refractory cases. So the consensus also emphasized that laser therapy is more of an adjunct rather than monotherapy. I think we all combine them with topical therapy, whether it's the triple combination therapy, hydroquinone, or even azelaic acid, and so many other agents. Tranexamic acid can be combined with laser or light therapies to treat the vascular component of melasma. So this is a busy-looking algorithm that we published. But important here is I've already told you that for diagnosis, the role of Woods-Lamb dermoscopy, skin biopsy, initiate photoprotection. For mild melasma, where roughly the modified PASI is less than 4 or so, topical agents like hydroquinone, 2 to 4%, azelaic acid, kojic acid, vitamin C, arbutin, all these can be used. For moderate to severe, it's mainly the triple combination therapy, but the one that contains fluocinolone acetonide. Newer non-hydroquinone agents are already there if there's intolerance or contraindication, including thymidol, cysteamine, Melasil, malacession, and metformin. Maintenance and skincare is important after you review at 4, 8, and 12 weeks for any side effects of hydroquinone like ochronosis or topical steroid-induced side effects, and rotate or taper to non-hydroquinone agents, continue photoprotection and moisturizers, cosmeceuticals with bioactives, plant extracts, and hydrating agents, and reassess periodically for recurrence or resistance. Now, if there is not much of a response, we go to the second line, which is chemical peels, or the oral agents like tranexamic acid or oral antioxidants. And again, third line is laser or energy-based devices like the Q-switched Nd:YAG laser, picosecond laser, IPL, PDL, and radio frequency. Again, for recalcitrant melasma, microneedling and intradermal injection in combination with topical agents, tranexamic acid or platelet-rich plasma seems to be having good evidence, although it can also be used alone. So I conclude by saying that these are some important conclusions. This consensus highlights the importance of a comprehensive approach to management, emphasizing photoprotection, topical therapies, oral therapies, and adjunctive therapies. The recommendation also underscores the importance of addressing patient compliance through cosmetically acceptable formulations, and most importantly, education on proper skin care. Now, by integrating these recommendations, dermatologists can optimize outcomes. So what we did is, these were some global practices. We did not take up those which are not used so commonly. So I'd like to thank you for your attention. And if you want to really read more, I have Melasma, a monograph, book that I have edited, and it's available in its, 4th edition in case you want to read more about it. So thank you very much for your patient hearing.
Thank you very much, Professor Rasmi, for the excellent and insightful presentation. On behalf of the committee, we apologize for the incorrect presentation of Professor Rasmi's CV. The following data is the correct one. Professor Rasmi Sarkar currently serves as the Director Professor of Head of the Department of Dermatology at Varman Mahavir Medical College and Safdarjung Hospital in New Delhi, India. Her profound impact on global medical science is well recognized. She has been consistently listed in the top 2% of scientists globally in the prestigious Stanford Elsevier reports for both 2025 and 2024. Professor Rasmi leadership footprint spans across major dermatological society worldwide. To highlight just a few of her remarkable roles, she served as the Regional Director of the International League of Dermatology Societies in 2023. She is the past president of IIDVL on 2022, and she served also as the chair of the ILDS Education Committee, vice chair of the board of ASPD, and secretary for the Asian Society of Pediatric Dermatology. Thank you so much, Professor Rasmi Sarkar.
Thank you, Dr. Paramita.
Thank you. And before we get into the discussion, let me remind all of the participants that tonight we have two special programs. First, we have an exclusive webinar recognition program for international participants, offering an international registration fee waiver up to $500. This will be given to 5 lucky questioners and 5 lucky people who share tonight's webinar on their Instagram stories. International participants, please share this webinar on your Instagram account by tomorrow, 25 June 2026. And don't forget to tag our Instagram account at Aruna Summit ID. Winners will be announced on 26 June 2026. Second, specifically for participants from Indonesia, there is a special prize for those who register now until 27 June 2026. Please use the promo code listed on the screen. Maybe you can screenshot it first and register after the webinars end. Secure your place at Aruna Summit, which will be held on September 4 till 6, 2026 at Raffles Hotel, Jakarta. Ladies and gentlemen, we will now move to the discussion session. I will invite Dr. David and also Professor Rasmi to answer the various questions submitted by the participant. Okay, first we have a question from the participant. Wait. Okay, we have so many questions here, Dr. David and Professor Raskar. First, for Dr. David, thank you for the impressive presentation. It is from Nurmala. I would like to ask, how about other supplementation such as glutathione or astaxanthin for melasma? How effective and how long we should give to the patient?
Regarding the other antioxidants, there's no study saying that it is effective or not. But I always ask, most of our patients believe that they will take vitamin C, and some of them already taking glutathione actually. And as we know that glutathione is not well absorbed. Yeah, it's not, most of the glutathione are not well absorbed. And how good does it work? Actually, there's no strict high quality study. Astaxanthin, I also cannot find as well. But I do think that astaxanthin is more useful than glutathione. It is my personal view. Thank you.
Okay, thank you, Dr. David. How about Professor Rasmi, do you have any experience using glutathione or astaxanthin for supplementation in melasma management?
See, what I would like to say, usually the antioxidants which are available, what we have in India are a mixture of a number of antioxidants, right? They may have vitamin C, they have a couple of others, because to be very honest, we do not know which is the one single agent which is the best, right? I have done studies on oxidative stress, but they've shown multiple things like, for example, superoxide dismutase, catalase. It shows that there is a imbalance in a lot of them. So we don't know which is the best. So usually what is used is a combination of antioxidants in a particular, capsule that we are using. Having said that, glutathione has always generated interest. And I would request all the the audience that please read our article. Glutathione, what is its role as a skin whitening agent as well as in melasma? What is the evidence? What does the evidence say? This is published in 2025 in the International Journal of Dermatology. That examines what is there in evidence. Evidence shows that although there are studies using glutathione in melasma, there are both, studies that are labeled as, very well done, but there are more studies which are not so well done actually. So the conclusions are again not very effective. So having said that, that means that glutathione at best acts more as an antioxidant, not so much as a pigmentation reducing agent per se in melasma or in the normal skin. So I think if we use antioxidants, it is better that we use a combination of them that is available.
Yes. Okay. Thank you so much for the comprehensive answer, Professor Rasmi. We have next question from Riva for Dr. David. Given the growing evidence supporting the role of vasculature in melasma, do you use vascular laser in your practice? What modality is most effective for addressing the vascular component in melasma?
Yes, I do that. Many of my melasma patients they come with ectasia. Partly it's also due to the previous treatment itself, and I use a V-beam perfecta. So I think it is better I mentioned the brand of the lasers, V-beam perfecta, 595 nanometers. But I use of course low energy as well. So we don't want to see a darkening. That then I'm not using the 400 microsecond. I'm using 1.5 millisecond instead. So using low energy, and we don't want to see the blast of the vascular itself. Yeah. So anything I do, actually, I don't give more trauma to the skin itself. But I'm using V-beam perfecta. I think 595 nanometer is the best wavelength for vascularization.
Yep. Thank you, Dr. David. The next question is from Dr. Shreya Megji Karania for Professor Rasmi. Can only oral medication and topical treatment help reducing melasma?
Yeah, I think very much so. But having said that, let me say that melasma is a chronic disorder. So this is something that is going to go on for years and years, So you have to keep treating. There will be phases when it becomes lightened. You have to maintain treatment and come back. So you can treatment, whether it is your triple combination therapy or any of the monotherapies, like I showed in the algorithm, that you can go and use hydroquinone, non-steroidal agents. You can do that, and once you have started with topicals, you can add oral agents like tranexamic acid, as you know, is a game changer. So 250 milligrams twice a day works well. So it can be from 3 months to 6 months. Of course, you do monitor the patient. It shows that it is more or less a safe drug, but we can never be too sure. Whenever we have too much of a good thing, we have to be careful. So you can continue doing that for quite some time. It is only at some point if you feel that, it's not working so well, and when you're giving a gap, then you may have to maintain with so many other agents, which I showed, in my slide on algorithm.
Okay, thank you. Thank you so much, Professor Rasmi. We have the next question from Fanny Santoso. I'm Fanny from Surabaya. I would like to ask to both of the speakers, in patient with the compromised skin barrier or coexisting rosacea, how do you introduce topical like hydroquinone or retinoids without triggering side effect or irritation? Thank you.
Dr. Sharma, please. Dr. Rasmi, sorry, Professor Rasmi, please.
Yeah, so this is, of course, a good question, but again, it doesn't have a very perfect answer. But having said that, let me tell you that supposing, you feel that there is a barrier impairment, it is there, to a certain extent. In most of the patient, you'll have to be a little careful. Patient has to be individualized. So use a barrier, repairing cream that is a moisturizer, a good moisturizer. Moisturize your skin well. Sunscreens have to be good. So that sunscreens should be a hydrating kind of a sunscreen that you're using. Be careful about that. Go slow, maybe with things like hydroquinone or triple combination. One way is you need not use triple combination therapy every day in the week, when you have a skin which is, very dry with a lot of barrier impairment, you can use it maybe twice a week. And in between, you can use something, which are the non-hydroquinone agents, but again, go slow. And you may have to, give day on and day off like that. I mean, although it is not set, and maybe just use it, 2 or 3 times a week. But having said that, use a good amount of moisturizers.
Yeah, for me, when the patient got irritated skin, of course, I will not do hydroquinone treatment or any treatment that containing retinoid as well. If the patient come already with rosacea and also with melasma, and I should ask my patient what is the trouble them much, melasma or rosacea, and of course we can address both of the disease together, but I will avoid those treatment that can cause more irritation. Like when we choose sunscreen as well, sunscreen also can be part of the irritation. Yeah, so we have to be careful with the sunscreen. Sunscreen can be part of the irritation. And the other thing is we can avoid hydroquinone, use a non-hydroquinone treatment. Yeah, so we may use niacinamide. Yeah, we may use cysteamine, short contact. Yeah, only 5 minute to 15-minute contacts and other. So we should try and error. And of course, in this case, post-dilator 595 nanometers, I think it will be a good help for rosacea as well. Yeah.
Another thing, I'll add to Dr. David's list is azelaic acid,
Yeah.
But again, be careful with that because sometimes it irritates. So you can start off, with something like 10 minutes. Wash it off, then gradually build it up, to 20 minutes, 30 minutes. And that treats, both partly your melasma, partly also your rosacea, which is there. So you have to be a little careful. And definitely tretinoin, is something which can cause more of redness. So can steroids. So you can do it if you're using triple combination, go very slow. Once you've used a lot of moisturizers or use any of these agents, but build them up, gradually.
Yeah, thank you so much, Dr. David and Professor Rasmi, for the comprehensive answer. We move to the next question from Belinda. I want to ask a question to all of the speakers. We understand that the use of TCC cream is time limited and requires tapering off. Could you please explain in details and technically how you perform TCC tapering in practice? Thank you.
For Professor Rasmi, For
For
me?
Professor Rasmi and Dr. David, maybe
Oh, yeah.
Professor Rasmi can answer
Yeah.
first.
Yeah. So as I mentioned also in the algorithms, you don't just blindly go in for triple combination. You have to look at the patient. If the patient has already been using many treatments, you may not use it. But if in case the patient comes to you fairly early in the treatment, you can use triple combination. Having used it, say you look at the patient at 4 weeks, as I mentioned, 8 weeks and 12 weeks, everybody may not need it, for 12 weeks. Look out for side effects, of both topical steroid, because in our country, topical steroid misuse is more of an issue. And hydroquinone, usually in that short period, you don't have ochronosis, but you have to still look out, you have to be careful. After that, normally I taper, all of us agreed to taper. So it could be, say, 2 times a week, which can again be given for a period of, say, the next 1 to 3 months. And you gradually introduce the non-hydroquinone agents which are there. There's so many of them, like, as I said, azelaic acid, but of course there is cysteamine. There's also thymidol, which is a lighter agent. And Melasil, you have, these are available. We don't have Balacession available, but these are agents which are actually quite well tolerated. In fact, thymidol is something that is tolerated quite well. It doesn't have the burning or something. So maybe when you're going down on the triple combination twice a week, that is where you can introduce the thymidol.
Thank you, Dr. Professor Rasmi. Dr. David, maybe you have your thought on this.
Yeah, I always be carefully with TCC, because sometimes when we use TCC, when the patient come, and I always ask the patient what medicine they have ever been already used by the previous doctors. Because most of the patients that come to us is not the first time to treat. Many of them are recurrent. And I ask them, and sometimes I just do try once, about 2 or 3 times a week of TCC, see what happens. If there's no irritation, I go every night. And then if there is improvement, I slowly decrease it. And I decrease and alternate with a non-hydroquinone and non-steroid and non-tretinoin as well. So because Terima combination, there is a steroid, so there is a hydroquinone, there's a tretinoin, so I can create more vascular factors. Yeah. So as we know, that vascular factor is not a good idea. So when doing tapering off, I alternate with the non-hydroquinone and non-TCC, and slowly I will stop. And sometimes I ask patient only once a week use TCC.
Okay,
Instead
thank
of,
you. Yeah. Thank you so much, Dr. David. We move to the next question from Dr. Rasmia Rawawi. For Professor Rashmi, could you share your experience in the treatment and management of exogenous ochronosis? Professor Rasmi, please.
Yeah, see, exogenous ochronosis is again something which is not very easy to treat if you've reached that stage. Initially, you suspect it when it becomes, your melasma starts darkening a lot. It's not the usual lightening. It is an unusual color. It's almost becoming bluish black. But once you reach, caviar-like, papillations, and that is when, you have a lot of ochronosis that is rather difficult to treat. One is that go slow on your topicals there. So not only do you have to avoid hydroquinone, but there are certain other topical agents which also have a molecule which resemble hydroquinone to quite an extent, like arbutin is one of them. And there are a couple of others, so you may have to be careful. It's not just hydroquinone. You may have to also go slow on, other topicals like hydroquinone. And then, of course, these probably may need something like a physical modality, once you have something like a well-blown, ochronosis, that is maybe when your lasers may come in, in case you have to treat, ochronosis, because nothing else, once you have, those caviar-like papillations which are available on the skin and all, it's very difficult to treat that. But go slow on other treatment and just use moisturizers and sunscreens. And with some time, some of it, does become a little bit better, but you may, physical modalities could be little needling, could also be a fractional laser. And there is not much of a perfect answer actually on this.
Okay, thank you so much, Professor Rasmi. We move to Dr. David. What is your opinion about using microneedle to apply anti-pigment agent or PRP to treat melasma? Because in such treatment, we intentionally break the skin barrier and induce inflammation. Thank you. Question from Mary
Oh,
for Dr.
yeah.
David.
My opinion is using a microneedle as actually is a to facilitate the absorption of the topical agent that we are going to apply. And the aim is not to apply a harsh treatment like many passes, and only one passes, and use it very shallow needles just to break the stratum corneum. Just to break the stratum corneum to facilitate the absorption of the PRP or whatever anti-pigmentary agent that we want to push go faster inside. So in my clinic, instead of doing that, I use a thulium lasers, but I set in low energy, just to break a little bit of stratum corneum. So it too has, but there is another opinion is using radiofrequency microneedle to treat the base membrane, to improve the base membrane and the upper dermis quality. So there is, I think there is a brand of Korean microneedle they are promote for this purpose. But I personally don't use that technique because it's very difficult to determine it is overstimulate or understimulate. So I prefer do is very carefully. And regarding that previous questions about ochronosis, it is practically very difficult to treat. So do not push hydroquinone faster or deeper into the skin. Be very careful about using hydroquinone, because when I was in Japan, almost no Japanese doctor use hydroquinone in my time when I was trained to be a dermatologist. So I use hydroquinone very carefully. Sometimes I use only 2% instead of 4%. Thank you.
Thank you. Thank you, Dr. David, for the comprehensive answer. Maybe that is our final question for this session. We apologize due to the time limitation. We may not be able to answer all the questions. Once again, thank you very much for Dr. David and also Professor Rasmi for the very interesting discussion on melasma. Maybe we'll see you again at
Thank you
ARUNA
very much.
in September. Have a nice day, Dr. David and also Prof. Rasmi. Thank you
Thanks
so
for
much.
inviting us. Thank you.
Thank you so much.
Thank you, Professor Rasmi.
Thank
Thank
you,
you,
Dr. David.
Dr.
Thank
David.
you,
Pleasure.
Professor Rasmi.
Thank you so much.
Okay, so now we can move to our next session. We are privileged to have with us a physician of remarkable academic pedigree and extensive professional expertise hailing from India. Allow me to introduce Dr. Asim Sharma, MD, DNB, MBA, FRCP. Dr. Asim Sharma is a physician with a formidable list of qualifications, holding an MD, DNB, MBA, and the prestigious fellowship from the Royal College of Physicians of London in dermatology. His academic journey is a testament to dedication and excellence. Today, Dr. Asim Sharma will share his clinical experience in dealing with melasma cases with the topic entitled Pro and Con, Controversies in Melasma Management. Dr. Asim Sharma, you will have 20 minutes and the screen is yours.
Thank you very much. Am I audible?
Yeah, all is clear, Doctor.
Superb. So thank you very much again for having me and for everybody who's logged in. I've intended to prepare this lecture for our colleagues in India and Indonesia. So I'm going to throw in some ascemisms or some things which I believe, and some things, most things which are evidence-based. So I'll try to keep this nice and crisp because, and before we start, the reason why melasma has so many controversies is because this is the one place where science meets desperation. So this is the one place where we have a lot of science, we keep working towards science, but because there is so much desperation, because we can't seem to cure melasma, we don't have a cure even till today. As we speak, we do not. And we also have a lot of people who use traditional medication, who come to us with Instagram reels, with tips and tricks on TikTok. We don't have TikTok in India; it's banned for us. But you guys have, and I know that a lot of your patients come with TikTok advice and Facebook advice. We also now have Claude, Chat GPT, and Perplexity. And trust me, every day you'll have a new treatment, things you won't even have heard of. I'm going to take you through a few of them, but also maintain that there are still a few things which younger dermatologists don't like, which still do work in the realm of melasma. So I'm going to begin my lecture now on pros, cons, and controversies. And truly speaking, melasma is the disease that humbles dermatologists. I think I spend the most time in my clinic now counseling patients of melasma as I do patients of vitiligo. I think these are two diseases which we should really speak about. And for somebody with a darker phototype, which is all of us in the room here, something like melasma or vitiligo, something pigmentary, does have a very, very big psychosocial role to play on our self-esteem, our psyche, and social interactions. So I've already told you why melasma breeds controversy. There is no single pathogenetic model which explains all cases. You had two lovely lectures by Dr. David and Dr. Rashmi, two people who've done a lot of groundbreaking work in melasma. And you realized one thing, right? Melasma is rarely limited to only the melanocyte. It's about the keratinocytes above, the fibroblasts on the side, and the endothelial cells below. It's to do with the sebocyte or the oil gland. People are also now exploring the mast cells to have a role in melasma. So just by treating the melanocyte blindly, we're never going to get anywhere with melasma. To be able to find a cure, we do need to target the dermal melanophages in some way. And that is where melasma becomes controversial and relapsing, which is why so many of our patients come to us with treatments that we don't really like, but we do have to address, right? And if you look at triggers, you have UV plus visible light, you have melanocyte hyperactivation, you have dermal inflammation, which has a major role to play. So a lot of aggressive procedures also can cause inflammation. So we're a little cautious when we do procedures. I'm going to speak to you about pulsing of radiofrequency, low fluence of Q-switch lasers and pico lasers, but I'll speak to you about that in a few minutes. There's also vascular signaling which needs to be stopped, which is why tranexamic acid in all its forms has done brilliantly for melasma. In fact, even today, if I have to tell you two things which have changed the way I practice melasma, one is tranexamic acid, which came obviously after we passed out, and the other one was hydroquinone, which we kind of imbibed from our seniors. These are still two agents which, when used cautiously, when used in the right dose, in the right patient, for the right duration, they can work wonders in patients of melasma. Like I said, for us, higher Fitzpatrick phototypes, the quality of life burden is often disproportionate. You could have just a little bit of melasma, and it could really, really shake your confidence and shake your being. And because both India and Indonesia have a lot of other people who give out advice, right, from chemists to neighbors to beauty parlors, non-dermatology physicians. So it does get to a stage where by the time patients come to us, they've tried a lot of things and they've had everybody telling them how to, treat melasma. In fact, in India, we have a running joke. We're very fond of cricket, right? So in India, people know the treatment of melasma and they know how to play cricket. So we will criticize everybody who plays cricket or all dermatologists who treat melasma. And relapsing is the major cause why patients keep coming back to us. There's also sometimes diagnostic overconfidence. So I always feel, and we were taught as residents that Wood's lamp is the single most defining criteria. But if you read data on Wood's lamp very critically, for darker phototypes, Wood's lamp doesn't seem to be very reliable. It's a very observer variability is very high when somebody uses Wood's lamp, which means that if I and somebody else in the audience does a Wood's lamp for a patient, we'll probably get different results. So Wood's lamp accentuates epidermal pigment in darker skin more than it does the dermis, and it has a poor sensitivity for a dermal or mixed pattern, which is why I think completely switched over to dermoscopy. I would, if I have to leave you with one pearl today, please embrace dermoscopy. Look for the extent, look for the depth, look for the pattern, and look for blood vessels, vasculature, and also rule out mimics. A lot of us in India treat lichen planus pigmentosus and pigmented contact dermatitis, which initially could mimic melasma. I mean, there are different patterns, obviously, but to an untrained eye or to an early eye, you might be confused. So that's another place where you should be able to rule out mimics. Let's start with the first controversy. Let's start with the fun of the evening. So the sunscreen controversy, right? We're now looking at sunscreens which are touching 140 SPF. And I'm obviously going to ask the audience, and you can leave it in the chat box. Do you really think 140 SPF is going to cut it? And do you think it's a marketing gimmick, or do you really think SPF above 100 has a role to play? The 1 to 1.5% extra UV rays that SPF 100 blocks over 50 is not worth the financial burden. We do prescribe it in India. We prescribe it to patients who want SPF 100, but I tell them, if you apply SPF 50 every 2 hours when you're outside, when you're exposed, that is a much better strategy than to apply SPF 100 once a day. So in India, SPF 100 is sold as a once a day application. I absolutely disagree with that, and that's the first controversy. I would much rather that my sunscreen's SPF 50, which is reapplied, and targets visible light. So instead of having vertical height or more and more SPF or a higher number, I would rather have breadth. I would want my SPF to have UVB. I would want it to have UVA or a PA plus rating. I would want it to have protection against visible light. So I would want a broad spectrum sunscreen rather than having a narrow spectrum sunscreen, which is high SPF. You also need coverage from infrared light, and from all the young people who are now spending a lot more time on Instagram, on TikTok, on Facebook, on the internet, I think a blue light coverage also is given. So obviously blue light is nothing but high energy visible light, but you should look for coverage for visible light as well. So any tinted sunscreen, golden rule, we used to have titanium dioxide based sunscreens, but they leave a very bad white cast, so they're not used very commonly in India. I'm sure you don't use it in Indonesia as well. But we do use tinted sunscreens now, which come with micronized zinc oxide. Micronization causes it to cause a less white cast, a thinner layer. These are always marketed as invisible sunscreens. Physical, mineral, invisible sunscreens. They have a definite advantage in melasma because they can block visible light, which is another trigger for the melanocyte and that surrounding milieu to erupt and worsen melasma. So let's move on to topicals. Like I said, I'm a huge fan of hydroquinone. I still use hydroquinone. When I was a resident, I used to use the 4% variant as cream. Now I use the liposomal variety because I have fancier patients. But the fact remains the same. Hydroquinone is almost always the first thing I write on a prescription. But how I use it is very important. I do not use it for every single patient. I don't use it for an irritated barrier. Dr. Rashmi spoke about barrier beautifully. I'm going to come back to that in the next few slides. I use the 4% or the 5% hydroquinone serum. I give it initially. I put an end date on that. I sometimes do a weekender therapy where I give them Saturday and Sunday of hydroquinone and 5 days of a different agent. But I definitely do use it in my practice. And if you notice any launches which have happened in the last 20 years, any topicals that have been launched, even some devices, by the way, they have compared themselves to 4% hydroquinone, which means 4% hydroquinone is the standard comparator, which means that definitely works. The game changed in 2020 when something known as the CARES Act in the United States banned the OTC use of hydroquinone. It made it prescription, which I think is a great thing, because something like hydroquinone being sold over the counter and being abused for months together, that is the reason why ochronosis comes into being. And that is a very difficult and challenging condition to treat, like you heard the last two speakers speak about. So use it as an induction course, do time-limited courses, give your patients hydroquinone either on a weekender basis or give it for a total of 2 to 3 months and then wash it out. Change it over to something different, because you have a lot of other topicals which can be used in alternate. The next thing is Kligman's formula. Do I use it? Yes, a little less than I use hydroquinone now. But again, if I'm stuck, if I have refractory melasma, if I have patients coming who've taken treatment for melasma and they are not happy, or long-standing melasma, anybody who's had melasma for more than 5 years, they come to you, they are not getting better, I would start using the triple combination, again, in the same format. I mostly use triple combination on a weekender basis. I never use it daily because the abuse potential in India is very high and we get Kligman's formula for very cheap, sometimes even under 200 rupees, as opposed to the newer thymidals and melicils of the world, which will cost upwards of 4,500 to 5,000 rupees. So what about the maintenance phase of topicals? I'm a huge fan of azelaic acid, but azelaic acid is a molecule that you have to respect. If you use azelaic acid in the wrong formulation, which is either a gel-based formulation, which is higher than 10%, or a cream-based formulation that is higher than 15%, it has a high likelihood of irritation. Again, I use the liposomal version of azelaic acid, find very good results to it. Azelaic acid is the one molecule which does not have a very good Instagram page. It doesn't have a great following. It's not marketed very heavily, but it's one of the only agents which targets just the bad melanocytes. It only targets the hyperactive melanocytes, the abnormal melanocytes which cause melasma, which are swollen up and laden with macrophages. It does not target the normal melanin, which is why if you have a patient of vitiligo and melasma, and trust me, that combination is common, you will treat that patient only with azelaic acid because you do not want demelanizing of the normal melanocytes. Plus, it's a category B drug for pregnancy, so I give it in all my pregnant patients who have acne PIH, and melasma. One of my first lines there, and it's a steroid-sparing maintenance after hydroquinone. So this is again something which I use very frequently. For the serum formulation, use anywhere between 10 to 15%. For cream formulation, use 15 to 20. I'm not a very huge fan of gels just because of the humidity that we have in India and the skin types that we come with. Cysteamine came with a bang. In fact, Professor Rashmi Sarkar and I were she was one of the first people to do the research on cysteamine, get it to India. And when it was launched in India, we were one of the first people to work on it and use it. Initially, the smell was very, very bad when patients would come and return the cream to the clinic because the smell was bad. But a few companies mastered the art of adding a few things to it and negating the smell, masking it. Cysteamine is an all or none phenomenon, which means it will work for some patients well. I still have patients who use it very well. They use it for 30 minutes, wash it off as a short contact period, and then move on to another demelanizer. But the patients it doesn't work for, it doesn't work at all. So it's something which you have to test and try. I call it the apremilast of melasma. If it works for you, it works for you. If it doesn't work, it won't work at all. Niacinamide and retinoids. I think retinoids for me have made a major comeback in the last decade. I really feel adding one exfoliator to the mix does make a change when it comes to melasma. And this for me is absolutely non-controversial. Please use some form of, you have now retinyl esters, retinols, retinals, and tretinoin. So either of these agents can be used, but you have to use something which exfoliates the skin unless your patients are coming in for chemical peels on the side. So always think of melasma as you trying to target simultaneously the melanocyte, the fibroblasts, the endothelial cells, and the keratinocyte. And you're also trying to prevent some triggers, which are UV light, which are hormones, which are a few medications, which I'll speak about, and stress and inflammation. So if you, in your heads, make this algorithm, you'll be able to treat these simultaneously. So chemical peels, they are combination tools, not monotherapy. All of us know that. You cannot use chemical peels in unison. Sorry, give me just 1 second. Something wrong with my audio, just 1 second. Hi, am I audible now?
Yes,
Yes, sorry. I think my AirPod ran out of battery, so I changed
okay.
it.
It's okay.
Okay. So when you think of chemical peels, don't think of them as monotherapy. Think of them as something that you're using in combination with the other therapies that you have. So like I said, these are exfoliators. They remove the top layer of the skin, and that is how they contribute towards pigmentation. The same job can be done by a topical vitamin A derivative, but again, you can do it much faster in the clinic. And melasma patients, initially at least, need faster results because they come to you with some expectations. That's where I do chemical peels quite a bit, but don't do it as a monotherapy as some people do. Start low, start with maybe a smaller molecular weight peel, start with a single peel, and then you move on to multi-active peels. And before you do a chemical peel in your patients, please prime your patients. We are darker race, we need priming, otherwise your peels themselves can cause PIH. So make sure that you're doing that in the right way. But yes, if you look at risks in skin of color, definitely 5 to 7, or rather 4 to 6, which is where we are. Those are high risk areas. So if you are in doubt, send the patients back, give them a good barrier recovery, give them something which will prime the skin for a couple of weeks, and then call them back and do chemical peels. This is usually what I follow in my clinic when we treat melasma in new patients. Okay, this I think is the biggest controversy in the last 2 decades, whether to use tranexamic acid or not. I was fortunate when we started using it a decade back. I had done a debate on this, and it was one of the most watched debates, I think, in PigmentaryCon, which Professor Rashmi Sarkar runs in India. It's a great meeting which is run in India. So I think it's the evidence anchor of this talk. If you look at evidence now, there is a recent meta-analysis which has studied 4,000 patients, studying the doses that are used, and at 250 milligrams twice a day, or even 750 milligrams per day, up to 9 months. The only side effects that were found in that were gastrointestinal irritation and headaches. No evidence of venous thromboembolism or any thromboembolic or procoagulative effects at that particular dosage in 4,000 patients at a lower dose. See, we use a significantly lower dose of tranexamic acid. When you look at what is used by emergency physicians or gynecologists, they often use 1 to 2 grams per day. We're using 250 milligrams twice a day, sometimes even 250 milligrams once a day for maintenance. So it's something that I really want you to I call it the Beyonce of melasma treatment. There are 3 formats. One's the oral, which is the most studied and the most effective. If you don't want to give the oral, or you're scared, or your patients are not fitting that typical phenotype where you want to start them on oral, if they're older, if they're women who have a history of miscarriages, or they're smokers, or any old history of thromboembolic episode, you can also use intralesional tranexamic acid. Those of you who are going to attend ARUNA, I'll be speaking on this as a separate session there, but it's something that can be done. Topical tranexamic acid and peels for me are not very effective, but if you don't have any other option, if you're giving them the oral or the intralesional, it's a good add-on. On their own, I am not very fond of either of these molecules. Anyways, they come in combination with other things in a tube or in a peel bottle. Tranexamic acid is also one of those things, before I forget, which works not only on vascular endothelial, the endothelial cells, it also works on mast cells. So it's targeting 2 out of the 6 things that we need to target in melasma. Let's look at devices. I think this is the most important thing. When I was a resident, we were told don't laser patients at all. You will increase inflammation, which was a point that we took sourly. But now we've come to realize that you can give results in melasma. You can use devices in melasma as a first line as well, even though we still use it in combination with other things. We don't promote it as a first line agent, but it's about how you use the device. If you have a Q-switched laser, an Nd:YAG laser, use it in a low fluence, high spot size. So open up the machine, use a spot size of 8 to 10, bring your fluence down to below 1.5 joules per centimeter square, and then use melasma. The aim should not be to heat up the skin or to hit the pigment hard like a tattoo. The aim is to tone the skin. So as long as you're laser toning, that's a very good strategy to use in our skin types, because you don't want to destroy the melanocyte. Again, I won't talk about laser physics right now because I don't have a lot of time. Picosecond lasers are preferred now because of the photoacoustic mechanism. But if you don't have the budget for it, if you have a good Q-switched Nd:YAG laser, there are ways and means to use a low fluence and cause the least thermal effect. Not as much of an acoustic effect like a pico laser, but you can get decent results with a Q-switched laser as well. Pulse dye lasers have a lot of studies now when you look at melasma because of the vascular component. In our practice, we use a fractional probe of the Q-switched laser, which makes it even better. I'm very fond of fractional Q-switched lasers along with maybe exosomes or PDRN applied topically, and they really do well for our patients of melasma. Microneedling RF, again, there are standalone studies on microneedling, standalone studies on microneedling and radio frequency. The idea there is to not give a continuous wave of RF because that is 40 degrees centigrade. You don't want to cause any inflammation. So the idea there is to use a pulsed mode. So your machine should have a pulsed mode where you will pulse the wave instead of giving a continuous wave of radio frequency. But all possible bodies of evidence reviews consistently place devices below topicals and tranexamic acid because of recurrence, because of PIH, and mixed durability of the results. And there's also a lot of inter-operator variability where I can probably give better results than you can, or you can probably give better results than I can. Things that should not feature on your treatment menu. This is another controversy. I think a lot has been spoken about IV glutathione. If you ask me honestly, I was never a fan of IV drips in the first place. I rarely give them. But even when I do use the oral formulation of glutathione, I use the orally bioavailable, the melt in your mouth formulation of glutathione. I feel that has a slightly higher bioavailability, maybe about 60 to 65%, as opposed to oral glutathione, which is 35 to 40%. But I use it as an oral antioxidant. I do not promise fairness. I do not promise skin lightening, and that is not to be done. The problem with glutathione is the results are temporary. You'll take it, it'll work, you'll stop it, it'll come back. So use it smartly as an antioxidant. Stick to the oral formulation. Maybe do not use the drips. Anything mixed along with glutathione these days, the likes of NAD and such, I don't use them in my practice at all. There's also there's something which is very viral on TikTok and Instagram right now, which is called the peel-off mask. There's an academy which is claiming to teach you how to do that particular peel-off mask. It's simply a charcoal peel-off rip. It's not to be believed. It's absolute gob. I have patients coming. I've had patients in the last 2 weeks who've come. In fact, a patient had shown this video to me. And this is something which you shouldn't believe in. Your patients will come to you asking for the 3-day glow. That is untrue. It's just a peel which is peeling off the skin. So please don't fall for that particular video. What are the two overlooked axes? One is hormones, which we've spoken about briefly, and the other is barrier. You need to be able to maintain barrier, especially because some of the treatments that we do with melasma, they do disrupt the barrier. So we need to repair barrier along with all our treatments. The real controversy in melasma comes from maintenance. I think enough has been spoken about that. The treatment for melasma never finishes. Once your patients are done with the induction phase, once they're done with your procedures, they need to get on to maintenance phase. And that is where I use a lot of these newer molecules which are there in the market. My patients also seem to like it quite a bit. And they have a good enough evidence base to continue after the initial treatments are done. So your good management, as per all the guidelines that I could find, including the one that we published, you confirm the diagnosis, eliminate the triggers, protect from visible light, induce using a triple combination therapy or 4% hydroquinone or a non-hydroquinone derivative, or even a procedure at this point. Add oral tranexamic acid, even if you do it in a pulsed form for a few months in a lower dose. Use devices for refractory cases for sure, and transition to the maintenance as early as the induction phase goes and patients are happy. I promise my patients 65 to 70% results from baseline. The minute they hit that, I shift them onto maintenance. And this is my last slide. 9 truths I'm going to leave you with. Tinted SPF with iron oxides is your most evidence-based intervention. This is level 1 evidence in melasma. Azelaic acid is underused, underrated, but a very, very old horse in melasma. Oral tranexamic acid has better evidence than anything I've showed you today on a presentation, apart from sunscreens, hydroquinone, and triple combination. HQ still works, but use it smartly. Cligmens is only induction. Put a timestamp on it. IV glutathione is an antioxidant, not a fairness elixir. The patient who's found something on Instagram is not foolish. They are desperate. Meet them there and tell them what you would do instead of what they come to you with. And melasma is a chronic, persistent disease. I don't even call it relapsing anymore. It is a persistent disease. It's going to stay with the patient for life, pretending to be a cosmetic problem. Don't treat the cosmesis, treat the patient there. Thank you very much for a patient hearing, and I'm sorry if I overshot my time by a couple of minutes. Thank you.
Thank you, Dr. Asim Sharma, for the exceptional and illuminating analysis of the controversial elements in the melasma management. Now, I'm pretty sure our audience has many burning questions, so you can all drop your question to chat box or Q&A box. Later on, Dr. Asim Sharma will answer in the Q&A session. Thank you, Dr. Asim Sharma.
Thank you.
Okay, so we will move to our final speakers, Dr. Inneke Jane Hidayat, SPDVE, MKes, FINSDV. Dr. Inneke earned her Bachelor of Medicine from Atma Jaya Catholic University of Indonesia, Jakarta. She then pursued her specialization in dermatology and venerology at Universitas Padjadjaran Bandung, as well as her master's degree. Driven by a passion for continuous learning, she also completed her fellowship training at Siriraj Hospital, Mahidol University in Bangkok, Thailand. Dr. Jane will share her experience in treating melasma cases in a presentation entitled Real Case-Based Experience in the Management of Melasma. Dr. Jane, you have 20 minutes and the screen is yours.
Okay, thank you so much. Okay, thank you so much, Dr. Mita, for a very kind introduction by you. And today I was given the opportunity by Aruna and also Admire Academy on sharing the real case-based experience in treating melasma. And in this opportunity, I would love to share with you about to explore the role of injectables in melasma treatment. Yes, this is something quite new, but however, the improvement or the development in treating melasma by increasing or improving the skin quality is getting more and more our. So I think the shift from Hi, I was told that my voice is a little bit breaking down. I hope now the voice is getting better. So, okay, so I am given the opportunity to share with every one of us here a real case-based experience in treating melasma. So in this opportunity, I would love to share with you about how I use injectables in treating as an adjunct in treating melasma, as we have listened to our previous speakers that still topical treatments are the first line treatments and lasers or any energy-based device are adjunct for treating melasma. So the dual nature of pigment in melasma, it is beyond just melanosomes, because these days, as we know that we are shifting to a regenerative aesthetic medicines, and this give a new insights of how dermal environments, of how the fibroblast senescent and trying to regenerate the skin quality is something that plays a significant role in treating skin quality, including melasma and photoaging. As we have listened to Dr. Darto or Dr. David has mentioned how photoaging also influenced the resistance of melasma or recalcitrant melasma. So I think by reversing the photoaging or treating the photoaging by improving the dermal environment is really giving a good or significant effect in treating melasma. Other than that, as we'll listen to Dr. Asim, he also mentioned about vascular hyperactivity, and we're going to see how by improving the skin quality by injectables can actually target these three important components in treating melasma, which is dermal environment, vascular hyperactivity, and also improving the barrier dysfunction. Okay, so there are a lot of studies that have shown how the role of dermal fibroblast is actually important in melanogenesis. And these are some of the latest findings, and there are still many more. And how is the precise role of dermal fibroblast on melanocyte pigmentation, or in this case, melasma? As we can see in younger skin, the functional basement membrane, something that is very hype in treating melasma these days, that is very, it is most discussed about improving the dermal epidermal junction or the basement membrane can actually help in treating melasma. And as you can see in older skin, there is a dysfunctional basement membrane, and we can see by the dysfunction basement membrane can actually cause the pendulous melanocytes, which clinically can be seen as a dermal melasma. One of melasma that is really hard to treat, and we can use lasers. However, the improvement sometimes is not as significant as we are expecting. So how is the mechanism of action of PDLL-AHA that I am sharing with you right now can help with treating melasma? So as we can recall back about how fibroblast senescent can actually impair the dermal epidermal junction. So by injecting the PDLLA, which in a microsphere form, we can actually first give a mechanical tactile for the fibroblast, for the senescent fibroblast, to attach to the spherical form of the PDLLA. And then if the senescent fibroblast is being stretched, it gives a signal for the collagen to start the neocollagenesis process. Other than that, it will give a controlled inflammation process to create a neocollagenesis other than the fibroblast stretch. So there are two mechanisms. First is how we stretch the senescent fibroblast to be more active. Second is the controlled inflammation, a subclinical inflammation that can enhance the neocollagenesis. As we know, wound healing still needs a pro-inflammatory cytokines to have a very good wound healing result. However, it has to be controlled. So by using the PDLLA, it actually gives a controlled inflammation to start a neocollagenesis. So findings have shown that PDLLA has the anti-melanogenesis effect and also improving the microenvironment of the skin. And last but not least, it is something that we are looking in regenerative medicine. So how does the anti-melanogenesis effect can happen in PDLLA injection? So we see that first, by the anti-inflammatory actions. By M2 polarization or macrophage 2 polarization, that means there will be an increase in anti-inflammatory effect. So as a result, it will decrease the pro-inflammatory effect that is induced by reactive oxygen species or other external factors that can induce the pro-inflammatory cytokines in our skin. It can be barrier dysfunction or irritation on the skin or ultraviolet and also air pollutants. And not only that, also this physical stress that is induced in our body can actually enhance the reactive oxygen species. And these reactive oxygen species will then cause the increased abnormality of vascular reactivity and also increased inflammations. And by the macrophage 2 polarization, it will decrease those pro-inflammatory cytokines. Then we know that the inflammatory cytokines can induce melanogenesis. By reducing the inflammatory cytokines, it gives an indirect effect of the reduced melanogenesis in melasma patients by injecting PDLLA. Second, it is seen that the interleukin-10 is increasing, and also the increase in the adipocyte stem cells proliferation. And this gives the paracrine effect to the fibroblasts, to all the cells surrounding these the areas that has been injected by PDLLA. Hence, the result is the increase of the fibroblast proliferation and the decrease of the fibroblast senescence. And as a result, there will be an increase in the collagen and elastin fiber formation. And other than that, by reducing the pro-inflammatory, it also reduces the matrix metalloproteinases enzymes. Those enzymes are degrading the collagen and elastin. And by the synergistic effect of these mechanisms, it will improve the dermal epidermal junction. It increases the collagen. It increases the natural hyaluronic acid in our skin. So it will improve not only the dermal epidermal junction, but also the epidermal barrier. It increases the hydration. Hence, it will give a protective effect from the external stimuli to our skin, not only by also improving the dermal melasma or the melanocytes, not to be more pendulous. Okay, so what are the findings that have shown how PDLLA is actually reducing the melanogenesis? So these are the histological findings, how actually injecting PDLLA, as you can see in the histological findings, in a skin biopsy being exposed to ultraviolet. As you can see, there will be an increase in melanogenesis and also disruption of the collagen and elastin and also the retiridges. However, injecting the PDLLA, as you can see, 4 weeks and up to 8 weeks after injection, you can actually see the melanogenesis is reduced compared to the one not being injected to the PDLA. You can actually see histologically and also from the skin biopsy itself. And not only that, even after 8 weeks of injection, you can actually see the improvement of the red ridges. So let's see for the next one. Here we can see the translocation of pro-inflammatory cytokines and also the inflammasomes and the expressions of those enzymes that degrades the fibroblast or the collagen and elastin. As you can see, the one being exposed by the ultraviolet, you can see the marker is increasing compared to the one being injected with PDLLA. And up to 8 weeks, we can compare to the one irradiated with ultraviolet. The marker are not as much as the one not being injected with PDLLA. And as you can see here, these are it is showing the nitrogen. Nitrogen is something that is important for the attachment of the dermis to the epidermal areas. And as you can see in the skin injected with PDLLA, the nitrogen marker is actually increasing compared to the one being irradiated with ultraviolet. That means even though it is irradiated by ultraviolet, being injected with PDLLA, the nitrogen can still be intact or even improving. So I will summarize how the mechanism works using the PDLLA and HA injections on helping to treat melasma. First, the immediate of the HA effect that is contained in the preparation of the injectables. The HA effect, of course, we know that it gives the immediate hydration and immediate glow, something that our patients would really, really love to see it clinically because it gives an immediate water retention in the extracellular matrix. And also HA have the capability to reduce the reactive oxygen species. However, because we know that this is a non-cross-linked HA, so it is easily degraded in our skin. So this is where the sustained PDLLA can work. It creates neocollagenesis, increase the collagen and elastin fibers, which gives a natural hydration in our body. And it also gives a vascular stabilization because it will reduce the abnormal vascular endothelial growth factors that is usually induced by reactive oxygen species or other inflammatory stimuli. And last but not least, the matrix health or the environment of the dermis area that will improve the melasma itself. Not only improving, but also synergistically can give improvement with other treatments. So the clinical evidence that has been found in treating melasma with PDLLA can be shown by this study, the efficacy of subdermal PDLLA injections in the treatment of melasma. And this is one of the studies, and also the preliminary evaluation of melasma being treated with microjet injection. And as you can see here, this is after 10 sessions of PDLLA. In 3 patients with variation of gender and also age. And as you can see, 7 sessions and even like 5 sessions, it gives significant improvement by reduced erythema and also the melasma. However, because this is a laser-driven microjet injection, so I question, what if I only give PDLLA injection without any laser assisted? Would it give the similar result? So I tried to inject patients with photo aging with PDLLA HA injectables. This is a protocol that I'm giving to the patients, intradermal injections, 3 sessions with 3 to 4 weeks apart with injection plane is intradermal. And then another treatments is protocol pigmentation that I now start to use is combining with other options of treatment in the melasma patients. So the treatment plan, the first patient that I'm going to show you is, initially I was treating her only to improve her skin quality. As you can see, she has double photoaging process on her face, the fine lines, the melasma, and also some solar lentigo and vascular lesions or redness on her mid-face areas. So this is how I inject the patient. I spread the intradermal injections on her face. So now we are going to see, I use the quantifier to evaluate the skin quality and also the photographic of the patients. You can see that 2 weeks after the first treatment, there's not so much improvement. However, the redness has improved, as you can see on the mid-cheek areas. And after 2 treatments, you can actually see the pigmentation starts to reduce and also improvement in the skin texture. And 1 month after 3 treatments, you can actually notice that the pigmentation initially on her mid-face area on the forehead is actually improving. So in this patient, we are not giving her any other treatments that can affect the melanogenesis. I only gave her moisturizer and also sunscreen. And you can actually see this is the improved skin quality after 1 month of treatment, and it's sustained until 6 months after without any topical treatment that can induce or reduce the melanogenesis. And this is the photographic picture that I use with not a skin analyzer, but common photographic or digital cameras. And you can actually see the improved pigmentation and improved fine lines and also the skin glow. And slight volumizing effect can also be seen on her forehead and temple areas. And because we're talking about melasma, we can actually appreciate the improvement of the melasma lesions. And on the skin area, we heard that how vascular reactivity can actually gives a significant effect on the formation of melasma. And you can see not only the melasma lesions is improving, but also the vascular lesions are also improving. This shows that how skin quality can actually help the skin barrier to give less reactive vascular that can enhance or induce melasma in your patients. So another patient, also female, around 50 years old, with the same regimen. This is you can see on her melasma lesions are getting better. Her skin tone is getting better. On her cheek areas, as you can see, she also have hori nevis here. And also the forehead areas is getting so much better. And also her skin is getting brighter. And this is another patient. You can actually appreciate also on her on the cheek areas, how her skin is improving after 3 treatments. She only has a slight melasma on her cheek areas. And you can really appreciate how by injecting the PDLLA can actually give improvement on her. So last but not least, I want to show you how actually by combining this treatment, Dr. Asim has mentioned about microneedle RF. In this patient, I used the microneedle RF with pulse wave, and we can actually see the improvement of skin texture and also melasma in this patient before and after. And not only that, by the microneedle RF, we can actually also improve the texture and the pores. And this patient also, you can actually see how her melasma is improving. I also treated her with PDLLA and that is combined with HA. So I think with that, I would like to close my presentation with thank you so much for your kind attention.
Thank you, Dr. Jane, for your time and for sharing your expertise. Don't go anywhere because we will back with our last Q&A session. Before we get into our last discussion, let me remind all participants that tonight we have 2 more special programs. We have one free day pass for one lucky Indonesian participant who share this webinar event to Instagram story latest on 25 June 2026. Don't forget to tag our Instagram account at arunaSummit.id. And for special for international participant, you can win free registration for Aruna Summit by submitting your abstract latest on 15 July 2026. You can submit your abstract to email scientific@arunasummit.id. Okay, so we'll go to our last session before we start. I would like to invite two more wonderful expert panelists of dermatology from India, Dr. Atula Gupta and Dr. Ishat Agarwal. Dr. Atula Gupta is highly accomplished dermatologist with an impressive track record in international leadership and clinical education. She currently serves as a board member and treasurer of the DASIL. Furthermore, she leads as the chair of the International Liaison Committee for the Association of Cutaneous Surgeons of India, ACSE. Dr. Atula Gupta has contributed over 20 publications and 15 textbook chapters to the medical community. And second, we have Dr. Ishat Agarwal, built his medical foundation at Sri Ramachandra Medical College in Chennai, where he completed his MBBS. He subsequently completed his postgraduate training in general surgery before finding his true calling in dermatology, earning his MD in dermatology from the prestigious Institute of Postgraduate Medical Education and Research in Calcutta. Dr. Atula Gupta and Dr. Ishat, are you here with us?
Hi.
Okay.
Hi.
Hi,
Can you hear
Dr.
me?
Atula. Okay, perfect. So we have Dr. Atula Gupta, Dr. Ishat. I will ask you one question. What is your experience in handling melasma cases in India? Maybe Dr. Atula first?
So I think we had a very good webinar, and as was discussed before, right? It's a chronic inflammatory disease, and counseling is the most important in melasma. It's no matter what we do, it's going to rebound unless sun protection is maintained. So yes, we do all the above treatments that were initially discussed. But I think it's very important that we understand that, if you're using lasers, especially Q switch lasers, if you're using, then we need to understand that there may be a rebound. If you're using tranexamic acid, you need to use, all precautions. So yes, it is something that remains, and counseling of the patients is most important. But I agree with all the modalities that have been discussed before. They're all useful, and a cocktail works very best.
Okay, thank you, Dr. Atula. How about you, Dr. Ishat?
Yeah,
Can you share us your
yes, I think
experience?
I feel that one thing that is very crucial in treating melasma is to understand that it's a very delicate balance of a lot of things that is happening there. And inflammation is kind of crucial to treat. So whatever we might do, anything that is triggering inflammation onto the skin has to be avoided and to be managed. So the fine line between doing treatment that is going to treat melasma or is it going to worsen melasma is very, very, very thin, very, very thin line there. So, for example, microneedling, yes, it's a great, I was listening to all the speakers talking about it. Yes, it's a great modality. But if you go a little aggressive with it and you actually disrupt the barrier, the dermal epidermal junction, it might just trigger melasma more. Same goes for the laser, same goes for all the topical treatments. So yes, while it is all these treatments are great, I think it's important to toe the fine line. Also, one of the crucial things as a dermatologist is to retain your patient with you, and therefore trying to understand what is the patient undergoing, when do they have events in their life? When do they have the travel? So having that kind of a connect with the patient, it's crucial so that you can change aggressive treatments when it is absolutely needed and then put them on some kind of maintenance when it's a quiet phase of life for them. So I think these are important pearls for me.
Yeah, thank you. Thank you so much, Dr. Ishak. So we move to the question from the participant from Dr. Indah Widyasari. For patient with recalcitrant melasma and has already tried almost everything available, topical, oral treatment, how do you reassess the case and what is the best plan we could give for the next step? Maybe first for Dr. Ashim Sharma.
So, on a lighter note, after hearing Ineke's talk, I would probably counsel them for PDLA or PDRN. I think that seems to be one thing which I have not consistently used in melasma. I'm quite a big fan of skin boosters and PN PDRN for melasma, but I've not tried PDLA, sorry. So I think that's one thing that can be tried. But jokes apart, I think if a patient's not responding to standard, I'm assuming tranexamic acid orally has been tried, good photoprotection, and a host of topicals ranging from triple combination hydroquinone right down till Merasil or Thymidol. I would probably relook my diagnosis first. I would try to assess if there is any component which I'm missing, if there's any pigment contact dermatitis which I'm trying to miss, because initially that can mimic melasma. If not, and if the melasma is dermal, I would want to do some treatment which will take care of the pendulous melanocytes, the deep melanocytes. I'd want to do something which works on the elastotic component or the solar elastosis or the fibroblasts. And I would definitely try to see if I can do something else for the vascular component. So this is the patient where I would continue, probably restart topicals per my whims and fancies, and I would do a couple of procedures. I would definitely do a fractional Q switch low toning. I really believe in that. It helps to break down the pigment a little bit. Patients start feeling better. The overall skin tone improves. And I would definitely try to do skin boosters here to be able to target the elastotic component as well, to stimulate the fibroblasts and to, kind of lighten the melanocytes along with fractional Q switch laser. But I would do procedures for a patient like this just to keep it short.
Okay, thank you, Dr. Ashim Sharma. What about you, Dr. Jane? What will you do if this patient already has a lot of oral, topical, many treatment, and still the melasma going back?
Yeah, I think melasma is something that is very difficult to treat, and how the patient actually taking care of the skin really influence how the melasma itself is occurring on her skin. For example, I think history taking is very important on how does she behave on her daily activity, such as under the sun, what is her hobby, if she likes to go and do activities under the sun, and as we know that it is actually related to very related to sun exposure. So I think it is something that we should discuss with our patients, and also any oral contraceptives or hormone replacement therapy that she is taking. So I think it is we need individualized treatment in our patient. And still, I think now it is important to aside then all those treatments to start targeting the skin quality in our patients, whatever the modality. It doesn't have to be PLA or HA. Anything that we can give for our patients to improve the skin quality and reduce skin inflammations on our patients. Yeah.
Okay, thank you, Dr. Jane. The next question is for all the panelists, for Dr. Jane, Dr. Ashim Sharma, and Dr. Atullah, also Dr. Ishad. For patient with ochronosis and history of steroid abuse, what is your first step and management plan? I think we have a lot here in Indonesia, the steroid abuse and the hydroquinone abuse. So what should we do?
I'll just take that. So the first thing that you have to do is, I don't believe in tapering the steroid off at all. You have to stop the steroid. A lot of people use Kligmans, I don't believe so much in Kligmans anymore. but you have to do the barrier repair first and tackle the steroid damage first. So we do that, we replenish the skin barrier and we make the skin stable. Now we come to the ochronosis part. So again, ochronosis, other than stopping the culprit agent, which is hydroquinone, it can be managed, but we understand that there is the skin is thickened and there's a deposit there. So it works. I use a lot of combination of fractional lasers, preferably non-ablative here, just to create transepidermal channels, and then Q switch to actually eliminate the pigment. So that kind of a combination, you can do it in different sessions, but that combination still helps. But I think fractional lasers are paramount when you are treating ochronosis.
Yep. Thank you.
So I
Dr.
feel
Ashim?
yes. Okay. Yeah. Let's simple.
Okay, Dr. Ishat, maybe you can go first.
Yeah. So I think Atula said it very right, but I feel that when you are stopping steroid, you need to counter the side effects that has happened because of so much of steroid use. So to bring down inflammation, I actually put my patients on pimecrolimus or tacrolimus or even topical JAK inhibitors. I feel they do wonders in reducing the inflammatory component of the skin. In terms of devices, I personally prefer the 595 nanometer gold toning device that I have in my practice. The other devices, such as fractional Q switch lasers and all those, I prefer to use them after good 3 to 4 months of barrier stabilization, reduction of inflammation, and stabilizing the whole, the inflammatory component of the skin there. And in these cases, again, I feel the oral tranexamic acid also helps by reducing the vascularity into this region. And I also give my patients a lot of antioxidants. These are the ways I manage the topical steroid rebound as well as the ochronosis.
Yep. Thank you, Dr. Ishat. Dr. Jane, any comment?
Yeah, so I think ochronosis is something that is very difficult to treat. It has to be something mm, has to be something that is mechanical as well. So I think picosecond lasers with the fractional ones probably can help, but yeah, still it is very difficult to treat. And for the steroid abuse, I think Dr. Mita, you are the best in like giving the comment about the steroid abuse. Yeah, because Dr. Mita here, she is a very strong advisors on about the steroid abuse.
Oh,
Yeah,
lovely.
yeah.
Okay. Dr. Ashim Sharma, maybe you have something to
So
say about
with topical,
steroid abuse, hydroquinone abuse?
absolutely. So with the topical steroids, I think I agree with Atullah completely. It has to be stopped cold turkey because you can go down to a lower potency. So there are multiple theories in practice. You can go down to a mid potency or a lower potency steroid. But the fact is, the minute they start getting rebound, itching, erythema, pruritus, or bumps, they will get back to the same level of steroid. I have sometimes given patients a short course of oral steroids, completely negated the topical steroids, then stopped the oral and the topical, and then continued with treatments like pimecrolimus is something I like a lot. Tacrolimus seems to burn a little extra in the initial few days. And treating these patients like I would treat a rosacea patient. So I use something like topical ivermectin or topical metronidazole. I think these agents, along with a great barrier moisturizer, they seem to work wonders with photoprotection. With exogenous ochronosis, the thing is you have to remove that entire upper layer. So you need to use a fractional laser along with a laser which targets melanocytes. So I do a Gaussian mode, a defocused mode of Q-switched NDAC, as opposed to the fractional one which I do for melasma. And I combine it with fractional CO2. Sometimes in the same session, if I want faster results, or I alternate. One time I'll do Q-switched NDAC, a defocused mode, and the other time I'll do a fractional CO2 device to exfoliate the skin completely. But that has to be. So we have somebody from India called Dr. Niti Khungar. She's done pilot studies on deep dermabrasion of the entire ochronotic area. And that's the level that we need to hit to be able to remove ochronosis. Otherwise, the ochronotic pigmentation stays forever. It's something which is permanent.
Yeah. Thank you. Thank you, Dr. Ashim. We move to our next question. So, What about other brightening agent in management of melasma such as melasil, cysteamine, thiamidol, kojic acid? Anyone has any experience and tips and trick in choosing skincare and topical for melasma? Maybe Dr. Atula first?
Yes, I'd use a lot of, and Dr. Rashmi discussed this, I heard her talk. Thymidol is an absolutely non irritating agent. I've been using it, and I think thymidol works very well. To be very honest, I don't think Kojic does much, right? I mean, it's still very mild to work on melasma. Histamine is established. But with the topicals, again, like, yes, like an antioxidant with a tyrosinase inhibiting agent like a vitamin C also, like a topical vitamin C. So obviously you put the patients on cyclical treatment. Like you can do twice a week of vitamin C, twice a week of thymidol. But then having said that, and of course, then your topical tranexamic acid, which again I have doubts on whether it really works too much, because at the end of the day, we are basically focusing more on sun protection. So all of these agents work. The irritating ones like azelaic, tretinoin, glycolics, these have to be really used short contact. But overall, if the patient does good sun protection and understands that this is mandatory, then all of these work in a cocktail. This is my understanding.
Yeah, yeah. Thank you, Dr. Atula. Dr. Ishad, any comment?
So for me, I think the cornerstone of melasma treatment is retinoids. I feel if your patient can tolerate it well, if you can modulate them well, there's nothing better than that for melasma because I truly feel they are the ones that actually work at the cellular level, at the epigenetic level. Another product which I feel which is underutilized is niacinamide because it is anti-inflammatory. It works in improving the longevity and the overall, it works on basically every possible pathogenic mechanism. So for me, I think underutilized ones is niacinamide and azelaic acid. I think if a patient cannot tolerate retinoids, I would want try them to try azelaic acid. And then comes thymidol, cysteamine, kojic acid, and all are probably maintenance molecules or some patient who's exhausted everything and wants to try something new, but they would definitely not be my first line agents of choice. And thymidol and cysteamine, I've seen it's either a hit or a miss. It either works or it doesn't. Sometimes it's very frustrating that they just don't show any change at all. So you have to really consider that as well.
Mm-hmm. Dr. Ashim Sharma, any comments, doctor?
So I largely agree with Ishad. I just have a differentiation of where to give thymidol and where to give melasil. Both are great molecules. Both have a different technology. So if you look at thymidol, they brought back bisoprolol, and it's a highly selective tyrosinase inhibitor. In fact, they say it's one of the most selective ones. But again, the most selective tyrosinase inhibitor is the unselective one, which is 4% hydroquinone. Nothing beats that. Nothing beats that in practice, at least. It might beat it on a white paper, but in practice, nothing beats hydroquinone for me, at least, as a first-line agent. So all of these are maintenance for me. Melasil has a slightly different technique where it prevents the uptake of melanin precursors. So it's more of a preventive therapy. If I feel my patients come to me with a single patch of melasma and I learned this from Dr. Dian at AMWC Taiwan this year, you have lentigo predominant melasma and melasma predominant melasma. So if you have those small lentiginous lesions, early melasma, I would prevent it by using melasil. If somebody comes to me with full-blown melasma, I'll start on hydroquinone and then taper down and move the patient to thymidol. Cysteamine is very all or none. I mentioned that in my presentation also. And please start using the serum formulation of azelaic acid. It's a game changer for my practice topically.
Thank you so much, Dr. Ashim Sharma. Dr. Ineke Jain, any comments?
Yeah, so I think hydroquinone for me is still the first line treatment, and also retinoic acid. What I want to target with retinoic acid or its derivatives is having a good regeneration of skin cells. So yeah, still the patients need it. It actually makes the skin more pliable and more resistant to the insults from the external factors. However, still the hydroquinone, the retinoic acid, it gives like irritative effect at the beginning. So educating your patients on how to use them is really important. And cysteamine, I think it helps. It helps if you want to have a maintenance phase without using hydroquinone. However, the smell actually it's not. Patients sometimes cannot comply with the smell. And last but not least, the Melasil, it is quite from the irritation side, it is less irritative from other topical preparations. However, still, if you want to treat melasma for the first time, I don't think it gives a fast result as hydroquinone, and I suggest to use it on maintenance phase. You can actually use it like not only at nighttime but also during daytime. So it's very good for patients who is already in the maintenance phase or is improved melasma. That's what I can give.
Okay, maybe we still have time, little time. So one more question for Dr. Ineke Jain and Dr. Ashim Sharma. Comparing to tranexamic acid meso-injection, succinic acid meso-injection, and PDLLA injection, which is the best result for curing melasma? Maybe based on your experience.
Inaki knows my answer, so I'll let her start first.
Okay, so I don't think there is any best one for curing melasma. I think everything is directed to different mechanism. Actually, it complements each other. Yeah, the three of them. So if you have those in your hands and it is targeting the indications, so I think you can use the three of them wisely, of course. Yeah. So I think because Dr. Asim also mentioning about injecting tranexamic acid, which I do not use in my daily practice. So I think Dr. Asim can share your opinion of injecting tranexamic acid.
Sure. So with injection tranexamic acid, we've gone through a lot of dilutions. And again, we spoke about it at Taiwan as well when we met, and I'll speak about it at Aruna again this end of the year. But what happens with tranexamic acid is it's not a replacement for oral tranexamic acid. Why it earned a bad name initially was researchers would say that you can either use oral or topical. But what oral does for dermal melasma, topical can, or the injectable form cannot do. So the injectable is again for early melasma. When you can see well-circumscribed macules of melasma, that is the right time to give intralesional tranexamic acid when you can give it in the border. The minute it becomes diffuse, that is where injectable fails quite badly and you need to move patients to oral. Tranexamic acid causes a lot of burning. It causes a lot of bruising. So that's something that you have to counsel your patients. I often combine this with plain hyaluronic acid boosters or PN-PDRN-based injectables. But the bruising is phenomenal, especially under the melasma patch. So that is somewhere where that's something that you have to counsel your patients. I use a very low dilution of it. And we can probably share the dilution if you need. And in that, it seems to work well for me, but for early melasma, well circumscribed, not for diffuse melasma.
Yeah. Thank you so much, Dr. Ashim Sharma, for the wonderful explanation. Unfortunately, due to the time limitation, we are unable to accommodate all of the remaining questions. So thank you so much, Dr. Ashim Sharma, Dr. Ineke Jain, Dr. Atula Gupta, and Dr. Ishad for the very interesting discussion. See you at Aruna on September. Thank you so much.
Bye. Thank you.
Thank
Thank you for
Thank you so
inviting us
much.
here.
Thank you so much,
Bye.
everyone.
Thank you,
Bye.
Thank you,
everyone.
Dr. Paramita. Amazing job. You held the show for 2.5 hours. I think that was amazing. You had to listen to everybody's talk and all the questions. I think fantastic moderation. Thank you so much for having us here, and we look
Thank you,
forward
Dr.
to seeing you in
Ashim.
Jakarta.
See you soon. Thank you so much.
Thank
So,
you. Thanks a lot.
as we come to the end of today's webinar, I would like to express our sincere gratitude to all of the speakers and also all of the expert panels for sharing valuable knowledge, clinical insight, and latest evidence regarding melasma management. I would also like to thank all the participants for your active engagement and thoughtful questions, which have made today's discussion both meaningful and also productive. We hope this session has helped clarify common misconceptions and strengthen our understanding of evidence-based approaches for melasma, ultimately contributing for better patient care. On behalf of the organizing committee, thank you. Thank you so much for your participation. I apologize for any mistake or shortcomings in moderating today's event. See you again at Aruna in September 2026. Thank you all. Goodbye. Have a nice day.
Thank you so much. Bye-bye.
Thank you, Dr. Rizia Paramita, and all of the speakers. This has been a wonderful session, very, very insightful intakes, and also we have all the practical knowledge that can be directly applied in daily dermatology and aesthetic practice, and also to combat misinformation. Okay, before I close the session, I have a couple of announcements. Okay, first, for Indonesian registrant, we have a one-day pass social media privilege. So please don't forget to share the story of tonight's webinar and tag at ARUNA Summit. Please make sure to share it today, because we will announce the winner of the day pass on 26th June. And the winner must contact Hello Aruna no later than Sunday, 28th June. We will announce it at ARUNA Summit in Instagram, so don't forget to follow us. And then for our international participants, we also have exclusive webinar recognition that we will have a fee waiver up to USD $500. This recognition will be awarded to 5 lucky questioners and 5 lucky participants who share an IG story. Please share your IG story and tag at ARUNA Summit no later than 25th June. We also June 2026. The submission. Okay, so we also have Indonesian registrant special offer. It will only be available from 24 to 27 June 2026. So as you can see, we have a lot of promo codes. So please take a screenshot and don't forget to register for Aruna, because as you can see from today's webinar, this is the standard that we hope to deliver in the our upcoming symposium on September. So please, if you enjoy today's webinar, you will absolutely enjoy our symposium. And last, for our international participants, we have also a call for abstract. So selected papers will be waived for registration fee and will be notified separately by email. The abstract submission deadline will be on 15 July 2026. So don't miss all of this opportunity. And once again, thank you to all speakers, moderators, panelists, participants, all Aruna committee members, and Admire Academy members for making tonight's webinar possible. We look forward to seeing you again in our upcoming Aruna scientific programs and at Aruna International Summit 2026. So with this, I conclude tonight's webinar. Thank you, good evening, and see you on September.
The future of dermatology is being shaped today. Aesthetic and regenerative dermatology are advancing rapidly. New technology, new therapies, and new scientific discoveries are transforming how we care for the patient. As the Indonesian Society of Dermatology and Venerology, we believe that progress must always be guided by science, ethics, and responsible medical practice. That is why we established ARUNA Summit 2026, a scientific platform designed to connect dermatologists, researchers, and innovators across our region. We invite you to join us at ARUNA Summit 2026 in Jakarta and be part of this shared vision.
When we start designing ARUNA, we ask one simple question. What should the future of aesthetic dermatology looks like? Today, our field is evolving rapidly with new technologies, regenerative therapies, and expanding possibilities in aesthetic medicine. As innovation grows, one principle must remain clear. Aesthetic dermatology must remain inclusive, evidence-based, and appropriate for all skin types and colors. Indonesia reflects this diversity, with patients across all skin of colors. That's why the theme of ARUNA is Global Aesthetic for Skin of All Colors. We want to create a platform where dermatologists can exchange knowledge, share clinical experience, and advance treatments that are safe and relevant with diverse populations. We look forward to welcome you to ARUNA Summit 2026 in Jakarta as we explore the future of aesthetic dermatology together.